All right, I think we can start. Time is moving on. Good evening, everybody. Hope you can see us and hear us well now. So welcome to another ESSO webinar. This time again, focused on neuroendocrine tumors. This is something ESSO has put on its flags this year, that we are focusing on neuroendocrine tumors because we believe there's a strong need for surgical oncologists to be trained in that. And we are very happy, Stefano Bartelli, my friend and colleague from Milan, and me to introduce fantastic speakers for this tonight's session. My name is Stefan Stettner. I'm from Linz in Austria, and I'm currently the chair of the Education and Training Committee. Let me say that this webinar is also sponsored by one of our partners in industry, from ITM. They are very important partners for us. And I can also tell you that no one of the speakers is getting any fees or honorarium for this talk. So please let me spend the next 1 or 2 minutes just to introduce our society. So what is ESSO, European Society of Surgical Oncology? We are quite a huge European association of different surgeons from all across Europe, but not only Europe, with partner disciplines and colleagues from South Korea, India, or Brazil, for example. We have a lot of collaborations. This is what we can provide. We do a lot of educational programs. We provide grants, a lot of in-person courses, and also webinars. And we have certification programs. So it's worthwhile to check out our website. And this is what I like on this picture. You can see how we try to deliver our message. It's always fun. It's networking. It's through a lot of personal engagement as well. And this is doing a lot in advocacy to improve outcome for cancer patients across Europe. These are some of the benefits you have if you join us. We really hope that you are already a member. But if you access our community, then you will have reduced fees, of course, for the Congress, for courses. You can have access to ESSO subscription. And it's probably the most important thing if you're more junior, is that you can create your network. And many of us have started with ESSO, our careers. So this is important. And lastly, this is my last slide. We do our annual meetings. This year in October, we are gathering in Gothenburg in Sweden from the 15th to the 17th of October. It's usually really a nice congress. We expect around 1,500 participants from all across the globe. And I can tell you that the abstract submission is still open, so the deadline has been prolonged for this. So thank you for listening. So I will now stop sharing my screen, and I would like to introduce the first of our great speakers tonight. It's Valentina Andreasi. She's from San Raffaele Milan, which is a center of excellence. We do a lot of courses. Valentina is a great surgical oncologist. And we usually start these webinars with a clinical case presentation. Valentina is giving us the first case. So please, at the end, you can always raise questions and put them in either in the Q&A or just send us a text message, and then we have the discussions at the end. So Valentina, happy to see you. The floor is yours.
Thank you for the introduction. I will just share my screen. Okay. Good evening. Tonight, I'm going to present a case regarding a functioning neuroendocrine tumor. I have no disclosures to declare. So this case is about a patient diagnosed with a functioning pancreatic neuroendocrine tumor. The patient is a male, aged 47, non-smoker, non-drinker, and at the time of our assessment, his weight was 50 kilograms, with a BMI of approximately 17. He had no known allergies, and in his family history, the only disease to be mentioned is hypothyroidism in his sister. In the past medical history of this patient, we have 2 autoimmune diseases, so a Hashimoto thyroiditis, although with euthyroidism in the absence of any medication, and a type 1 diabetes, which was diagnosed when the patient was aged 30. and he has been on insulin for approximately 15 years. Then we have previously eradicated Helicobacter pylori infection and irritable bowel syndrome. Previous surgery irrelevant, and in terms of medications, insulin and atorvastatin. So the clinical history of our interest starts in 2019 with several signs and symptoms developed over the course of 5 years, so between 2019 and 2024. So this patient experienced a progressive weight loss, overall 25 kilograms, of which between 10 and 12 kilograms were lost between March and June 2024, with a current weight at the time of our first assessment, as I was saying before, of 50 kilograms and BMI of approximately 17. He had no abdominal pain, no diarrhea, and he was able to eat normally with a normal caloric intake. He also developed a worsening glycemic control with an increased insulin requirement. So at the time of our assessment, he was taking short-acting insulin, 5 units in the morning and between 10 and 12 at lunch and dinner, and 38 units of long-acting insulin in the evening before going to bed, which is quite a high dosage, especially if we consider that the weight of this patient was only 50 kilograms. And also, he developed an itchy erythematous skin rash with pebbles and plaques involving the flanks, genital area, the elbow folds, and the forearms. And this skin rash initially was considered and diagnosed as atopic dermatitis. However, in 2020, as the skin rash was persisting, the patient underwent prick tests, which came back as positive for dermatophagoides. Therefore, he was started on topic treatments, although with no significant benefit. In January 2023, as the skin rash was worsening, the patient underwent a dermatological reassessment, and at this time, he had some grayish hyperpigmented lesions with scale crusts located in the sacral and bilateral iliac regions. And this rash was suspicious for chronic lichenified eczema. The patient underwent at this time a skin biopsy, which unfortunately was inconclusive, and he was started on oral steroid therapy. Initially, there was an improvement, but after ending this course of treatment, the patient had a further worsening of the skin rash, which led to a hospital admission. So in November 2023, the rash was extended on the trunk, limbs, feet, face, head, scalp, inguinogenital areas, and intergluteal regions, with erythematous squamous crusty patches. He underwent a new skin biopsy, inconclusive again, and also some skin swabs, which came back as positive for Staphylococcus aureus and Pseudomonas aeruginosa. And the diagnosis this time was likely impetigo. So again, he was started on oral steroid therapy associated with antibiotics. There was again an initial improvement, and then in February 2024, a further worsening of the skin rash with a new hospital admission. At this time, our patient was started on a medication called dupilumab, which is a monoclonal antibody active against interleukin-4 and interleukin-13, associated with topic treatments. There was again an initial improvement and then a bad relapse after approximately 1 month of treatment. So in April 2024, the skin rash, considered also the presence of anemia, was finally considered as secondary to a deficiency condition, likely an enteropathic dermatitis, possibly related to a zinc deficiency or pellagra. So he was started on therapy with zinc and vitamin supplement, and considered the presence of anemia, also underwent an upper GI endoscopy, which showed atrophic gastropathy. The biopsies were inconclusive because they reported only a non-specific lymphoid inflammation. Celiac disease tests came back as negative, IgAs were within normal range, and a seborrheic pemphigus was excluded as possible diagnosis. In May 2024, a new doctor who had never seen this patient before raised the suspicion of necrolytic migratory erythema. And based on this suspicion and on the presence of a possible pancreatic lesion explaining this kind of skin rash, the patient underwent for the first time in May 2024 a CT scan with contrast enhancement that you can see here, which showed a large solid lesion located in the pancreatic body tail, approximately 5 per 5 centimeters, with heterogeneous enhancement, some small calcifications, no dilation of the main pancreatic duct, and also there were no other lesions suspicious for distant metastasis. Afterwards, he underwent the measurement of glucagon plasma levels, which came back as highly raised, 1,450 picograms per ml, where the normal range is usually between 50 and 100. And he also underwent for staging a 68 gallium PET, which showed a pathological radiotracer uptake in the pancreatic body tail region, with no other pathological uptakes, so no distant metastasis. And to complete the diagnostic workup, this patient underwent also an endoscopic ultrasound, which confirmed the previous findings, so large solid lesion of 5 centimeters located in the pancreatic body tail with an arterial hyperenhancement followed by a rapid washout. The lesion was submitted to a fine needle aspirate, which came back as positive for a pancreatic neuroendocrine tumor G1 with a Ki67 between 1 and 2%. So at this point, we have a patient with a 5 centimeter solid lesion located in a pancreatic body tail, characterized as a pancreatic neuroendocrine tumor G1, highly suspicious for a glucagonoma, consider the clinical presentation, and no distant metastasis. Clinical presentation characterized by worsening diabetes with increased insulin requirement, significant weight loss, overall 25 kilograms, and a skin rash highly suspicious for a necrolytic migratory erythema. And this is just to show you how the patient appeared at our first assessment. You can see that there are these large indurated erythematous plaques with inflamed borders and central clearing spread out throughout the whole body. So we have a patient with a functioning, localized, resectable pancreatic neuroendocrine tumor, likely a glucagonoma. And at this point, we propose surgical resection as treatment. So in June 2024, on the 24th, he underwent a distal pancreatectomy with splenectomy and also cholecystectomy because he also had gallstones with a laparoscopic approach and associated skin biopsy. The pancreatic lesion was characterized as expected as a pancreatic neuroendocrine tumor staged as PT3, as the maximum tumor size was 4.2 centimeters and 0, so no positive lymph nodes out of 31 harvested lymph nodes, and G1 with a Ki67 between 1 and 3%. There was a focal infiltration of peripancreatic connective tissues, focal vascular invasion, and no perineural invasion. At immunohistochemistry, as expected, the glucagon staining came back as positive, and also the alpha cell lineage marker, so the glucagon-producing cell marker ARX came back as positive, whereas the beta cell lineage marker PDX1 came back as negative. And also a prescription factor related to the alpha cell lineage was found positive, this MAFB. So finally, in terms of follow-up, the skin rash almost disappeared within a couple of weeks after surgery. So these are photos taken preoperatively, and these are other photos of the same patients taken only 4 days after surgery. And you can see that there is a massive improvement in the skin rash. So in these postoperative pictures, we have only these hyperpigmented areas, no inflammation, the skin rash was not itchy anymore, and the patient was really happy about this big improvement. He also had an improvement of the glycemic control, which reduced insulin requirements. So at the time of discharge, the short-acting insulin dosage was 244 units as compared to 5, 12, 10 before surgery. And he was taking only 3 units of long-acting insulin in the evening compared to 38 units preoperatively. Unfortunately, he didn't become completely insulin-free because he has a concurrent type 1 diabetes, which was confirmed by positive anti-IA2 and anti-insulin antibodies. He regained weight, and now, 10 months after surgery, he is disease-free. Thank you all for your attention.
Thank you, Valentina, for this very interesting case. And Good evening also from my side. I'm Stefano Partelli and I'm a pancreatic and transplant surgeon and I work in the same hospital of Valentina, San Raffaele Hospital in Milan. I'm, of course, very pleased to share the moderation of this webinar with my friend Stefan. And I think the topic is very interesting, very complex, especially for surgeons. So I think now is the turn of an endocrinologist to put some order in this very complex disease. And we have the privilege to have a very expert in the field of neuroendocrine tumor, Dr. Olmo from Valencia. She will discuss about the initial assessment of patients with functioning neuroendocrine tumor. So please, Maribel, the virtual floor is yours.
Thank you very much. Good afternoon to all. I would like to thank the coordinators for their kind invitation. I am Maribel del Olmo. I'm an endocrinologist in University Hospital La Fe in Valencia. And today we will discuss how to recognize functioning neuroendocrine tumor syndromes, which is crucial to avoid intraoperative complications. Next.
Before we move on, do you see the full screen or the speaker preview? Is it the full screen?
I see the full screen, yes.
Okay.
Okay. So, okay. I would like to clarify that I have no conflicts of interest to disclose. Next. Next. So let's start. When you diagnose a functional NET, patients are going to start with symptoms. We are not going to diagnose a functional NET with a scalpel or with an imaging, with a CT scan or with an MRI. We have to diagnose them with our eyes, our ears, and a good clinical radar. So today, what we are going to do is talk about how we can challenge ourselves to have this good clinical radar and to diagnose them how with their symptoms. But first of all, we have to understand what is a functional NET. What does it mean to have a functional NET patient? It means that the patient is going to have specific hormonal symptoms of this hormonal secretion, not just only a positive immunohistochemistry or an increased hormonal level in the lab. We need the patient to have these specific hormonal symptoms. And next, when we talk about NETs, we have a lot of hormonal syndromes that can appear within a NET, but we are going to talk today to the specific syndromes that may be crucial in the perioperative status. Next. What I would like to answer throughout the talk of today is why is it important for a surgeon to recognize a hormonal syndrome, which syndromes matter and where to expect them, how to assess patients fast and meaningfully using symptoms, not just guesswork, and what not to do based on INET's guidance and real surgical implications. Next. So let's imagine you are the surgeon of this patient, a 58-year-old male, small bowel mass, stable preoperatively, that when he's in the surgical room, he develops during induction a violent flushing, his blood pressure drops to 60/30, and he has a bronchospasm, and it's diagnosed as an anaphylaxia. Or next. This other woman, a 42-year-old woman, who's scheduled for surgery of a pancreatic cyst, and suddenly the morning of the surgery, after an overnight fasting, she develops agitation, sweating, or seizures, and the anesthetist has to cancel the case. Or next, you can be the surgeon of this other man, a 49-year-old man with a chronic diarrhea who has dehydration and low potassium levels, and that within the surgery of this mass, he develops an intraoperative severe hypotension despite the fluids. In this moment, you would wish to be an endocrinologist, but you're not one. And it's important for surgeons to know when to call endocrinologists and to do the correct questions before they go to the surgical room. Because in this case, we should have known next that the patient had a carcinoid syndrome, or next that this other woman had an insulinoma, or next that this other man had a lipoma before the patient was in the surgical room. So this is why it's important for you to surgeons to recognize this syndrome. Let's see how to recognize these syndromes. Next. How do we diagnose a functioning NET? Well, basically we have two pillars to diagnose a functioning NET. The most important is clinical presentation, is to recognize these hormonal-related syndromes because, as we said, symptoms come first. And if we don't know these syndromes, we will never suspect that this patient has a functioning NET. And if we never suspect it, we will never diagnose it. And after that, we will have the targeted biochemical testing that will confirm our suspicion by the lab test and the hormonal excess in these labs, specifically to that symptoms that the patient has. Next. So, first of all, clinical presentation. Well, as surgeons, I can imagine that when the patient comes to your consultation, you either have the primary tumor diagnosed and its location, or sometimes patients have metastatic disease of unknown primary origin. Well, if we have the primary location, then we will ask the patient for specific syndromes. If we have a metastatic disease without a primary location, then we have to ask for all the symptoms of the most frequent functioning tumors. If the tumor is in the small intestine, we will ask for symptoms of carcinoid syndrome. If it's in the pancreas, we will ask for symptoms that rule out insulinomas, gastrinomas, bipomas, or glucagonomas. If the tumor is in the duodenum, we will ask mainly for gastrinomas, and if it's in the lung, for a typical carcinoid or ectopic ACTH. So next. Let's imagine that the patient in the surgery consultation has a midgut NET tumor or of unknown origin. As we said, next, the most frequent syndrome is carcinoid syndrome, that, as you know, is due to secretion of serotonin and other substances. These patients have a decreased quality of life and a decreased overall survival. And when we have next a patient with a midgut tumor or a patient with metastatic disease and unknown origin, the four main symptoms we have to ask for are flushing, diarrhea, bronchospasm, and carcinoid heart disease. So next, we have certain clues that make us think that these symptoms may be of a carcinoid syndrome. For example, next, the flushing of the patient with carcinoid syndrome is going to be a flushing of the face, neck, and upper chest. It is quite useful to know and to ask the patient about sweating, because flushing of carcinoid syndrome is usually dry without sweating. And usually we have to ask patient for triggers. This patient is going to tell us that after alcohol or certain foods, spicy foods, he's going to have this flushing, usually of a brief duration. About bronchospasm, we will ask the patient of symptoms like wheezing, shortness of breath. There are symptoms quite similar to those of asthma, and what is very peculiar is that usually these symptoms come along with the flushing of the patient. Then about diarrhea, diarrhea is going to be a common symptom on functioning NETs, but not all diarrheas of functioning NETs are going to be of the same characteristics. So if we are looking for symptoms of a carcinoid syndrome, we will see that diarrhea is usually secretory and it usually stops with fasting. So if the patient doesn't have, for example, dinner, he usually doesn't wake up at night because of the diarrhea. And then we also have to ask about the fourth clinical symptom, that is that of carcinoid heart disease. We have to look for right heart failure symptoms such as edema or ascites, and it's very characteristic to have only right-sided valvular fibrosis. So if we only see right-sided cardiac disease, we have to suspect a carcinoid syndrome. So next. If the patient in the consultation has a NET in the pancreatic gland, then we have to rule out other syndromes that we have to ask for their specific symptoms, as well as if it is a metastatic tumor without primary origin. Next. First of all, we have to ask for bipoma. As you know, bipoma is an infrequent tumor that takes place, that is usually in the pancreatic gland. And this due to this excess of VIP, patients present a Werner-Morrison syndrome. So next, the symptoms that we have to ask for in these patients to rule out a bipoma are mainly diarrhea. and mainly symptoms due to the electrolyte imbalance and disturbances that the patient have metabolically. About the diarrhea, certain clues can make us think of a lipoma. Next. As we saw in the carcinoid syndrome, that the diarrhea was secretory and stops with fasting, in the lipoma, it is a choleric diarrhea, watery, of more than 3 liters a day, that doesn't stop with fasting and that doesn't have food triggers, as we saw with the carcinoid syndrome. Next. Also, these patients have severe hypokalemia. So when we ask the patient, we have to ask for symptoms of hypokalemia that are mainly fatigue, anorexia, cramping, and muscle weakness. And then, and most important, we have to take a look at the historic analysis of these patients, because patients with lipoma usually have a lot of severe biochemical disturbances and profound electrolyte imbalances and metabolic derangements due to this VIP excess. Next. Okay, and next. The other tumor we have to rule out when we are talking about a pancreatic NET is glucagonoma. That is also an infrequent tumor that produces glucagon, that, as you know, is a hormone that produces glycogenolysis, gluconeogenesis, lipolysis, and hyperglycemia and weight loss. So next, in the case that we have a patient with a NET primary in the pancreas or of unknown origin, as Valentina showed in her case presentation, we have to look skin disorders, mainly necrolytic migratory erythema, for diabetes and weight loss. What about the clues here? Well, next, necrolytic migratory erythema, as you saw, it's usually painful and red, and it usually appears in the lower part of the abdomen and perineum. And also it has triggers. It usually appears in traumatic areas or in pressure areas, and is often confused with fungal infections. About diabetes, it's also a peculiar diabetes. It's not a diabetes with a type 2 diabetes phenotype, an obese patient. It's usually mild, non-ketotic hyperglycemia. And also next, due to the catabolic effect of glucagon, patients, although they have good appetite, they lose weight. And they usually are with malnutrition due to this excess of glucagon. So these are the things we have to take into account when ruling out a glucagonoma, as well as the diarrhea. Next. Then we have insulinoma, that we will see better afterwards. But as you know, insulinoma is one of the most frequent functioning tumors. The episodes of insulinoma usually are classically described by the Whipple triad, that is that the patient has symptoms of hypoglycemia that are documented with low plasma glucose levels, and a relief of these symptoms when the patient eats. So next. The symptoms we are going to ask our patient to rule out an insulinoma are those that are the classical that we can see in a diabetic patient, for example, with insulin, that are the adrenergic symptoms and the neuroglucopenic symptoms of a hypoglycemia. But it has certain peculiarities that we have to ask also in the consultation. Next. Hypoglycemias are usually fasting. We can have hypoglycemias in postprandial state in an insulinoma, but they are usually fasting. Next. Patients also have a gain of weight because to avoid these hypoglycemias, they eat frequently. And next. It is also important that hypoglycemia, due to the excess of insulin, is usually without ketosis. There's no fatty acid breakdown. So next. And then if the primary tumor is located or in the duodenum or in the pancreas, we have to rule out the Zollinger-Ellison syndrome, the excess of gastrin in the gastrinoma. So what do we have to ask our patient to rule out a gastrinoma? Next. Gastrinoma, as you know, it's an excess of gastrin levels that leads to this Zollinger-Ellison syndrome. So we have to be aware of recurrent peptic ulcers, to ask the patient about diarrhea, and also of abdominal pain and weight loss. So certain clues about these things is that when we talk about recurrent peptic ulcers, we have to see the history of recurrent ulcers or refractory ulcers to the standard treatment, or ulcers in unusual locations, for example, in the jejunum. Also, the diarrhea is different to that we saw in the carcinoid syndrome or in the lipoma. In this case, due to the excess of gastrin, gastrin inhibits the enzyme pancreatic, the pancreas enzymes. So these patients have steatorrhea. They are oily, the depositions. And it's also peculiar that when patients have diarrhea and we give them PPIs, it often improves the diarrhea of this patient. And also when we study the gastric pH, we obviously see an acid pH of less than 4. Okay, next. Okay, so after we have asked the correct questions in our patients according to the primary location, or in the case of an unknown origin, after we have asked all these symptoms of diarrhea, of flushing, then we have to do the targeted biochemical testing that confirms us that this patient has this syndrome. As you know, neuroendocrine cells are capable of producing biologically inactive substances and biologically active substances. Since we are talking about functioning tumors, we are going to ask in the biochemical testing for these biologically active substances. Which ones are we going to choose in the lab? Next. If we are in a small intestine, we will ask for serotonin and its metabolite, which is 5-HIAA. Next. As we can see in the INETS guidelines, when we have an SI-NET or a metastatic patient of unknown origin, and we ask for the symptoms, we said diarrhea, flushing, and carcinoid heart disease. If we think the patient might have this syndrome, we will ask for 5-HIAA. Next. In other guidelines, it says that in all SI-NETs, although they are not symptomatic, in the primary assessment, we should ask for 5-HIAA and only in the follow-up if it is elevated at diagnosis. Next. In the case of the pancreatic NETs, we are only next going to ask for the hormones, VIP, glucagon, insulin, or gastrin, only based on symptom suspicion. We are going to avoid broad panels. We are not going to ask for these hormones if the patient is completely asymptomatic when we ask for them. Next. And this is what we see also in the other guidelines. We are only going to ask for pancreatic peptides if in the first assessment or in the follow-up, the patient has symptoms compatible with a lipoma, a glucagonoma, or an insulinoma, because this way we are going to avoid false positive results and complicate the diagnosis of the patient. Next. So my take-home messages for today is that in functioning NETs, diagnosis starts with symptoms, not with imaging. So it's important to know these syndromes. Next. Because if you don't know these syndromes, you don't know what to ask, you don't diagnose these patients. Functioning NETs often masquerade as common surgical issues like flushing seems allergic, diarrhea can seem infectious, or hypoglycemia mistaken by metabolic imbalance. Next. Before the patient gets to the surgical room, we have to ask the right questions, like if flushing comes with sweating, like if ulcers are recurrent after PPIs, because missing these clues means missing the diagnosis and putting our patient at risk. Next. We only have to measure the hormones related to the suspected syndrome. So after asking the patient, after taking a look to the blood analysis, then we will ask for the hormones. We have to avoid broad hormone panels without specific symptoms. Next. The main thing that is why we are here today is that a missed functioning NET can mean a surgical disaster, as you saw previously. And next. To end up this talk, I would like to say that you should be the surgeon who knows when to call endocrinology, that we have to be proactive. Don't wait for an emergency to think of functioning NET. We have to think about these syndromes. We have to diagnose them before they get to the surgical room. And as we always say in NETs, we don't have to forget the importance of multidisciplinary team on NETs, because when we learn from each other, we win together. Thank you very much.
Well, thank you very much, Maribel. This was an amazing talk and not an easy task to bring all this in 15 minutes, but you've done it very, very well. And it just reminds me what I love most in NET, that we collaborated. It's really multidisciplinary treatment. So thank you very much.
Thank you.
So we have already 127 participants, which I really consider a huge success, but please put your questions in the Q&A or in the chat function, and we take them at the end. So the next talk is presented by Professor Julie Hallet. She will now go into detail with carcinoid crisis, which is also a very interesting syndrome, and it's very important that we as surgeons are aware of that. In the world of neuroendocrine tumors, Julie needs no introduction because she's, for me, really famous. She's giving great talks, but there might be some surgeons who haven't heard of her, so let me please introduce her. So Julie is working in Toronto at Sunnybrook Center. They have a huge and amazing neuroendocrine tumor network there. I know that Stefano just visited her for a couple of weeks ago, and she's very active in the field of NET. Just one example is the CutNets association that has just been created, and she's really driving research, clinical research in the field of NET. So Julie, thanks for joining us. I know that it's around lunchtime now. I think you have a busy clinic as well today, as you mentioned. So we're really glad and proud to have you here. Thank you very much. The floor is yours.
All right, thanks everyone. Just checking that you can all hear me well.
Yes,
All
we can hear you.
Sorry, as I'm ready to talk, my microphone decides to have issues, but seems like it's working now. All right. Okay, just give me a thumbs up that you can see this well.
Yep, all good.
Okay, so we'll get started. Thanks again for inviting me. I always love to talk about my favorite topic, neuroendocrine tumors, so I love having this opportunity. I also really liked hearing that we need as surgeons to know when to call the endocrinologist. I think that's a very good lesson for today. I would go a little even beyond that and saying that as surgeons, there's endocrinology issues that we need to know how to treat ourselves, because we cannot always rely on the endocrinologist holding our hands in the operating room. So that's what I'll try to cover today, talking about carcinoid crisis. And I think most people will know what carcinoid syndrome is, especially if you had interest in neuroendocrine or joining this webinar. But essentially, it's this hypersecretion of serotonin, happens most often in small intestine neuroendocrine tumors when there's liver metastases or where there's bypass of the liver circulation by hormone secretion, for instance, in retroperitoneal disease, or if there's a large amount of abdominal disease, or if you have bronchopulmonary neuroendocrine, for example. And those are the cardinal symptoms. We all know them: diarrhea, flushing, and wheezing. There's a few things in the perioperative setting that I think are very crucial with the carcinoid syndrome. The first one is that patients with carcinoid syndrome can have carcinoid heart disease, and that's damage to the valves and the endocardium from very elevated serotonin levels. Typically, it happens in the right heart, so tricuspid and pulmonary valves, as a result of the abdominal blood flow going directly into the right heart, but occasionally can also happen in the left heart. And that's more and more recognized these days. I think we realize that there's higher rates of left-sided carcinoid heart disease than we thought in the past. Like more recent numbers that we derived out of Ontario would indicate that carcinoid heart disease happens in over about 15% of patients that will have elevated 5-HIAA over time. I think historic numbers were higher than that because we didn't have the right denominator. But now that we have better data, that's probably what we're looking at. And it's more frequent in small intestinal neuroendocrine and in the presence of metastases. I don't think anybody is surprised by that. But something important to think about. The other important thing to think about perioperatively, already introduced to that concept, is carcinoid crisis. So that's sudden hemodynamic instability that will occur as a result of a carcinoid I want to say trigger, and you'll see why I don't talk about serotonin here in a moment. And that can happen with anesthetic surgery and invasive procedures, and eventually, if left untreated, will lead towards circulatory collapse and eventually death. When we look at prospective data monitoring for carcinoid crisis, the rate is about 25% in patients with small intestinal and metastatic neuroendocrine tumors. I know historical rates are much lower than that, but that relied on sort of retrospective chart reviews. And going back to something we just heard about in the prior talk, if you don't think about something, you won't find it. So I think that's what the prospective data on carcinoid crisis tell us, is when you're looking for it systematically, it's much more common than we used to think. What does that look like in real life? This is a patient I operated on a number of months ago, a young patient that has small bowel neuroendocrine tumor with bilobar liver metastases. As you can see, pretty high burden. He had carcinoid heart disease, underwent dual valve replacement in the right heart, and his 5-HIA was over 1,000. Our normal is below 40. So this is what it looked like in the OR. I took him for liver debulking after his heart surgery, and this is what happened. So that's over 3 hours, the anesthetic chart. So you can see that there is at least 5 episodes where his blood pressure dropped below 80, and those are carcinoid. And so what happens when there's a carcinoid crisis? This is from data from Rod Pommier in Portland, Oregon, where he gave pulmonary artery, like Swan-Ganz catheters to about 46 patients, like in everybody. And then he measured their hemodynamics, and then he also has a drop in blood pressure. He looked at the main hormones like the serotonin, bradykinin, kallikrein, and histamine. And what he found is that essentially carcinoid crisis is a state of distributive shock. Just give me 1 second. I think my computer is acting up again. And so it's a state of and importantly, when there was crisis, there was no specific hormone release that was identified. So we all think it's because of, if you study it, we cannot identify that. And that's important in how we treat things. So we'll just talk about this. So what I wanted to talk to you about mostly today is the results of an international expert consensus that we ran on carcinoid crisis. I think I was able to show that it is an important thing to talk about, but we also don't have any guidance really on how to treat this. There's historical approaches that lots of people have been using, but there's no real guideline. And so this is how we did this. We put together an international Delphi expert panel that was led by this steering committee that you see here, some people that you know from this webinar. And we ran through the whole perioperative care. There's anesthesiologist, and oncologist on this. So first step is the preoperative assessment. So very important to start by having a good assessment of carcinoid syndrome, and first identify if it is there by measuring 5-HIA. And this can be done with urinary 5-HIA. Some people will do it with serum, depending on what you have. Assess clinical syndrome as well, as we just talked about. If there is a carcinoid syndrome, this is probably one of the most important messages today: get an echocardiogram. You don't want to get a patient on the operating room table not knowing if they have carcinoid heart disease, because that's a difference between life and death for those patients once you put them under and start operating. If there is carcinoid heart disease, those patients need cardiology assessment, and if need be, they need cardiac surgery, and the heart comes first. All that needs to be done before we even think about operating on the abdomen. Then what about preparation? You've probably all heard that we need to give lots of octreotide prior to surgery to prevent carcinoid crisis. Now, this has been challenged quite a bit in recent years. So our consensus says that it is not needed to prevent crisis because there is no proof that it is efficient. Now, some patients will need octreotide to manage their symptoms from quality of life perspective or for cancer control, but for the purpose of preventing crisis, it's not needed before surgery. Why do I say that? I always like to go back as to why we're doing things the way we do historically. The way we do this is largely done because of this study from the Mayo Clinic. They had about 100 patients. And what they noticed is if they give nothing, there was a 10% rate of crisis. If they gave just injections the days prior to surgery, 17%. And if they combined injections and an infusion at the beginning of surgery, those patients had no crisis. This is, again, all based on retrospective chart review. And so there's issues with that as well in identifying crisis. And so based on that, everybody was like, okay, no crisis when you give both. That's what everybody should be doing. And that's what we've been dealing with for decades now. Now, when you look at this more prospectively, like Dr. Palmier's team did in Oregon in close to 200 patients, when he stopped using octreotide, the rate of carcinoid crisis did not change, sort of indicating that it's not very useful in preventing crisis. And so the way that we frame this in the consensus is that somatostatin analogs prior to surgery for the purpose of preventing crisis are at the discretion of the care team. We don't think they're needed. They probably don't hurt if people want to do it. I personally think it's annoying for patients to inject themselves for a few days before surgery, but essentially, it's okay not to give it. Other thing that's important, there was this idea out there that if you give certain serotonergic medications, it can trigger a crisis. One of those medications is SSRI. That's very important for mental health of a number of patients with neuroendocrine tumors. You do not need to stop that. Patients can carry on with it. It doesn't trigger a crisis. There's very good data from Sloan Kettering that it doesn't hurt. And then finally, make sure you optimize the patient like we talked about before surgery. What about the intraoperative management? We'll talk about the prophylaxis and then the treatment of crisis. So first off, I think we need to agree on a definition for carcinoid crisis. That's what we did with a consensus. You have it here, abrupt, significant hemodynamic instability. And the very important thing here is to confirm that there is no other factors that could create the hypotension, right? Hypotension happens for lots of reasons in the operating room. So the first thing to do is between anesthesia and surgery, talk about it and say, okay, this is a real crisis. The blood pressure did not drop because I'm twisting the cava, trying to expose the liver. It's a real drop related to crisis and nothing else. And so communication with the anesthesia team is exceedingly important. And we also encourage everybody to talk about this in the timeout when we operate on those patients, agree on how we identify crisis and how we'll treat it if it happens. With regards to prophylaxis, you'll see that this is a theme through this consensus statement. Bolus or infusion of somatostatin analogs or octreotide is not needed because it's not effective in preventing crisis. All the other things that we think we need to give, like antihistamine or ondansetron, also do not, there's no evidence that they prevent crisis. We don't need to do that. Keep things simple. And why do I say that? Again, going back to how things were set, that was a number of years ago from the group in Louisiana. They looked at a retrospective review again, retrospective chart review, and said that when they give bolus and infusion at the beginning of surgery, there was only 3% of crisis. So the conclusion was, it's a low rate of crisis, hence it works, everybody should do it. And we've been doing that for decades. Until Dr. Palmier again in Portland looked at this in more details, prospectively, and what he realized is this rate of crisis with a bolus and infusion of octreotide was the exact same as without octreotide or with other prevention strategies, and concluded that it's not reliable at preventing carcinoid crisis. And so again, our recommendation is that it is not necessary. We don't say it should not be used, but it doesn't have to be used, is the conclusion in the consensus. The thing that is, however, super important, if you remember one thing from my talk, it's the echocardiogram, and then this, maybe that's two things. So the goal when you deal with carcinoid crisis is to minimize the time of the crisis. The one thing that has been associated with increased major morbidity after surgery in patients with carcinoid syndrome is a carcinoid crisis of over 10 minutes. Not giving octreotide, not giving pressors, it's having a crisis of more than 10 minutes. So you want to minimize that. The way to do that is identify it quickly, treat immediately, and the best way to treat effectively is to start with vasopressors. And yes, beta-adrenergic pressors can be used and they are safe. That includes epinephrine and norepinephrine, and we'll talk about this in a second. And octreotide should not be used as first line. Why? Because it doesn't work. Essentially, it's not dangerous. It won't harm. What will harm somebody is if we use octreotide for so long without a result that we prolong the duration of the crisis. And so that's the idea behind it. Start with pressors because they work fast. At the end of the day, if nothing else has worked, might as well try octreotide, but it shouldn't be the first line. A word about beta-adrenergics, because that's like really ingrained deeply in surgical anesthesiology and even in patients' minds. It is safe. Again, same, Dr. Palmier likes to challenge dogma in neuroendocrine tumors. He looked at his patients who had this surgery, so close to 300 operation, 20% had carcinoid crisis. And there was no difference in the rate of hypotension between patients who received beta versus non-beta vasopressors. And so essentially saying that this is something that's been dispelled. We can use ephedrine, epinephrine, norepinephrine in those patients. And so the summary here is octreotide is not harmful. It's a very safe drug. But if it doesn't help, it can delay the use of effective treatment, prolong crisis, and that can be detrimental to patients. And the final thing we looked at is the postoperative care. So I know you're going to be shocked here, but one of the recommendations is postoperative octreotide infusion is not needed because it has no proof of preventing or treating crisis effectively. And if there's been a crisis intraoperatively, we recommend to consider the monitored unit at least for the first 24 hours to make sure patients remain stable. And so in summary, a carcinoid crisis is a life-threatening complication from neuroendocrine tumors. In particular, it happens in patients with elevated levels of serotonin prior to surgery. Important to have a good preoperative assessment and optimization that focuses on control of the syndrome, but also cardiac workup and management of carcinoid heart disease if it is present. Second, it's important to detect quickly the crisis intraoperatively, so be aware that it exists and that talk with the anesthesiologist, have a strategy up front. And if it is identified, treat it quickly, and that's with vasopressors as first line. And the third message is we do not need to rely on octreotide for prevention or treatment of crisis. There is no evidence to support that really, and we should use it only if all else fails when a crisis occurs. And with this, I'll just go back to this patient I presented at the beginning. This is, again, the same thing you've seen before. Each of those little square is 5 minutes. So what you can see is each crisis lasted less than 10 minutes because it was treated quickly. And that's where like teamwork in the operating room is crucial. This is the anesthesiologist I worked with that day, Dr. Perez. And this patient had carcinoid heart disease. It was identified. He was operated for it. We took the time for him to recover. In the operating room, we planned for a cardiac anesthesiologist to be there so he could have transesophageal echo monitoring throughout the operation. It was a big liver surgery. And then every time a crisis occurred, it was treated quickly with pressors. Not a drop of octreotide was used in that case. Dr. Perez was very proud of that at the end of the surgery, and the patient did very well. And with this, I'll thank you for your attention and look forward for, I suspect, lots of questions that will be triggered by the recommendations to not use octreotide perioperatively.
Thank you, Judy. Great talk as usual. So the next topic is another very important topic for surgeons. You know that the most frequent functioning tumors for the pancreas is insulinoma, and the insulinoma can be definitely a challenging disease, both for diagnostic and therapeutic point of view. So to address this topic, we have the privilege to have, I would say, one of the living legends of HPB surgery in Europe, but not only in Europe, with Professor Sauvanet, who works in the Hospital Beaujon in Paris. They have a huge experience for tumors, for pancreatic tumors in general, but especially for neuroendocrine tumors. I can tell you that there are a series of patients who are resected for neuroendocrine tumor is very impressive. So, Professor Sauvanet, the floor is yours.
Thank you, Stefano, for this invitation and for a very kind presentation. My talk is about pancreatic insulinoma, which is effectively a surgical disease, but not only. It's the most frequent functioning tumor. Usually it's a sporadic disease, but it should be known that some of the patients had the familial predisposition, mainly multiple endocrine neoplasia. It's a disease observed usually on the second part of the life, but it can be observed also in children. And the diagnosis is difficult, so the duration of symptoms before the diagnosis can reach several years. One fundamental point is the pathology of insulinoma. Insulinoma are small disease, small tumors, less than 2 centimeters in 80% of cases, that are sporadic, single in benign in at least 90% of cases. Only 10% are related to the genetic predisposition with multiple localization and or malignant. And there are almost always located in the pancreas. And if they are not in the pancreas, they are located on some exceptional pancreatic heterotopias. And there is no preferential localization within the pancreas. Some localization are easy to diagnose by imaging, but some other can be more difficult. What is the management of insulinoma? Insulinoma has a bad reputation. It's a dangerous disease, but it's not a surgical emergency. The diagnosis, the positive diagnosis of endogenous, spontaneous, inappropriate secretion of insulin should be established very strictly by endocrinologists and not by surgeons. We have some issue to solve. Is it a sporadic disease or a familial disease? Is it a benign disease or a malignant one? What is the exact localization? Should be used resection or ablation, because ablation had been recently developed by gastroenterologists. And if we perform resection, which type of resection? Insulinoma is a dangerous disease. The patient can have some hypoglycemia when driving, when doing sports. There is a possibility of seizures, of severe accidental lesions, but it's not a surgical emergency. The first step is to limit the risk of hypoglycemia. It can be done by surgeon, but I think it's very well done by endocrinologists. And since some patients with insulinoma are referred first to surgeon, I think that the surgeon should be able to refer insulinomas to endocrinologists, at least to treat correctly the risk of hypoglycemia by monitoring of blood glucose, meal snack education, limitation of sports, of driving, and appropriate medications. The most often used is diazoxide. Also, surgeons should know that every hypervascularized lesion within the pancreas in a patient with a suspicion of insulinoma is not an insulinoma, because there are several possibilities of hypervascularized lesions in the pancreas, which are not neuroendocrine tumors, such as splenosis, solid serous adenoma, metastasis of renal carcinoma. So CT is not enough, and the imaging assessment for a suspicion of insulinoma should be more complete than with a single CT. Second step is to obtain a strict diagnosis of endogenous inappropriate secretion of insulin. And it can be done by a diagnostic fast, which can last for up to 72 hours. And the patient should be admitted in an endocrinology unit, because this test can be somewhat dangerous. It's important to dose every important hormone, insulin, but also C-peptide, and to perform an assay of every drug able to modify the insulin secretion, mainly sulfonylurea, which can induce hypoglycemia. And if the patient takes sulfonylurea, or even in some exceptional cases, inject by himself some insulin, it's not a surgical disease, but a disease for endocrinologists, of a disease for even psychiatrists. Once the diagnosis of inappropriate secretion of insulin is done, the surgeon should consider that the presentation of the disease is very favorable, because it's a benign disease, a localized disease in up to 90–95% of cases. And since the tumoral disease is benign, as a benign behavior, a limited resection without any lymph node dissection is possible in up to 95% of cases. Conversely, it's not possible because for this parenchyma sparing procedure, there is some technical limitations, and it is estimated that only 60–70% of insulinomas are amenable to enucleation or central pancreatectomy. The risk of malignancy due to presence of lymph node metastasis or liver metastasis, as you can see, is very low, less than 5%. To localize the insulinoma, I think that's very no doubt about that. The most accurate examination, imaging examination, is PET CT with hexandine. It's an analog of GLP-1. It had been recently developed, and it's a most accurate examination to see the insulinoma. However, to localize insulinoma is not the only issue, because as a surgeons, we need some other examinations. CT to examine the peripancreatic vessels to assess the anatomy, MRI to assess the relationship between the tumor and the main pancreatic duct, or in some very rare cases to search for liver metastasis. And PET-CT with gallium-68 can show the majority of insulinoma, but we know that this examination has some limitation. EUS is useful to evaluate the relationship between the tumor and the main pancreatic duct. My personal opinion in this is when the landscape, the diagnosis is very clear, there is no need to biopsy the benign insulinoma, because this biopsy can compromise the best results of laparoscopic enucleation, probably because this biopsy can induce some inflammatory changes of some limited pancreatitis, which compromise the feasibility and the postoperative course of laparoscopic enucleation. In my country, in France, hexandine PET-CT is not easily available, and it's only reimbursed after failure of doctor localization. But we know that in some other countries, this examination is more easily available and probably reimbursed in every setting. When to suspect a familial predisposition, usually the familial history is clear. The most frequent disease is multiple endocrine neoplasia. In this patient, there are several PNET in the pancreas. Hypercalcemia is a very frequent finding. This insulinoma development are observed in younger patients. And in this setting, hexandine PET-CT is mandatory to localize specifically the tumor responsible for the insulin secretion. When to suspect a malignant insulinoma, they are usually revealed by symptoms quickly evaluating. They are associated with large tumors, with lymph node or liver metastasis. And I think in this setting that it's a clear indication to biopsy the tumor or the metastasis to determine the most appropriate treatment. But usually the insulinoma is sporadic, single, and benign. In this setting, the aim of treatments are to obtain a high rate of definitive cure, a low early mobility with no mortality, and no long-term functional disorders, and particularly no de novo diabetes due to surgery. I think it's rather paradoxical that a patient operated for a benign disease, a benign tumor secreting insulin, develop postoperative diabetes because the resection, the surgical resection was too extensive. There is an alternative to surgery recently developed by gastroenterologists. It's a EUS-guided ablation. This is a very interesting study from Italy comparing the results of EUS RFA with the result of surgery. Surgery is a more aggressive treatment with a more important morbidity. The clinical efficacy of surgery is slightly better than the efficacy of RFA. Conversely, the rate of recurrence is more important after RFA and probably much more important because the follow-up after RFA is shorter than the follow-up after surgery. And this limitation of RFA is confirmed by a series from an expert center of endoscopic interventional endoscopy from Belgium, 11 patients, only 83% of these patients are cured by RFA. There is 2 patients with a tumor residue and one have a clinical recurrence requiring a second RFA. With surgery, the long-term results are very impressive. The disease-free survival and the symptom-free survival, that's the most important, are more than 90% with a 10 years of follow-up. And the only patient who developed a recurrence are a patient who had a G2 tumor, N1 tumor, or had a previously undiagnosed multiple endocrine neoplasia. Which operation? This is a table comparing the different possible operations for benign tumors. Pancreatic duodenectomy, as you know, is a large operation and with a significant morbidity and some mortality. Total pancreatectomy is usually not performed for insulinoma. Spleen-preserving distal pancreatectomy have some rationale because the disease is benign, so there is no need to remove the spleen, even with tail localization. The problem is not the mortality, it's the early morbidity and mainly the risk of de novo diabetes, which can reach up 36%. The risk of exocrine failure is lower. Central pancreatectomy is mainly associated with a double risk of pancreatic fistula, and there is some death after this operation. Conversely, the long-term functional results are very good, and the most appropriate procedure from a surgical and functional point of view is enucleation, which is not a pancreatectomy, but only a resection of the tumor. The problem of this operation, to my opinion, is mainly for benign disease to prevent the risk of diabetes, to limit the risk of diabetes. So we have to limit the indication of pancreatic duodenectomy and distal pancreatectomy. The risk of de novo diabetes after this operation is at least 20% after pancreatic duodenectomy and up to 36% after distal pancreatectomy. If distal pancreatectomy is necessary, it's important to limit the extent of resection because the risk of diabetes is correlated to the percentage of resected parenchyma. And if possible, we have to perform enucleation or central pancreatectomy because the risk of diabetes is mainly lower, clearly lower with these two operations. But there is a technical limitation regarding enucleation. It's a distance between the tumor and the main pancreatic duct. The shorter is the distance between the tumor and the main pancreatic duct, the higher is the risk of pancreatic fistula. So a precise assessment is necessary by preoperative imaging. This tumor is close to the ducts, but adding evaluation, intraoperative evaluation with intraoperative ultrasound, we were able to perform an enucleation. Conversely, this tumor is very close to the main pancreatic duct, which is displaced, and there is no possibility of enucleation, and this patient had a central pancreatectomy. Now, the preferred approach for enucleation is the laparoscopic approach. There are a specific limitation of the laparoscopic approach in this disease. It's the difficulties of intraoperative localization, and impossible intraoperative localization is the main cause of conversion to laparotomy in this disease. The risk of pancreatic fistula is comparable to observed as an open approach, and as often with laparoscopic approach, the length of stay and the long-term quality of life is better than observed with open approach. Some practical surgical aspects. As a surgeon, you know that preoperative fasting is currently done, but in this disease, it's not possible if you don't give a routine glucose intravenous perfusion in this patient, because there is a risk of severe hypoglycemia at the end of the night, in the early morning. Intraoperative ultrasound is mandatory, and we don't know if the adjunction of sonoview is useful to have a more precise localization of the tumor in relationship to the main pancreatic duct. And some pancreatic surgeons have tried to enlarge indication of enucleation by using preoperative stenting of the main pancreatic duct. I'm not very in favor of this technique because we can observe pancreatitis after stent insertion and pancreatic fistula after enucleation, despite the presence of the stent. And some Chinese surgeons even are proposed to repair the main pancreatic duct, in some cases after intraoperative stenting of the duct. I think this result is very preliminary and should be confirmed by other studies. In multiple endocrine neoplasia, the historical approach was to perform even either multiple enucleation or a single enucleation in the and resection of the distal pancreas. I think these operations are outdated, and the modern approach is to localize precisely the insulinoma with PET hexandine and to perform localized targeted parenchyma preserving resection or an RFA ablation. So these are my conclusions. The FAST test is a key for an accurate diagnosis, and I think that the FAST test should be performed in majority before extensive imaging assessment. Imaging is at least CT plus MRI plus PET gas 68. EUS is useful for accurate localization or evaluation of a relationship to main pancreatic duct. Hexandine PET-CT is mandatory for any doubtful or frail localization or in MEN1. This disease is benign in more than 90% of cases, so a parenchyma preserving resection to limit the risk of de novo diabetes is indicated whenever possible, and enucleation in majority according to the relationship to main pancreatic duct. The disease-free survival after surgery is very impressive, and RFA should be known and could be indicated that the general condition is not equivalent surgery or when, but we have to know that the disease-free survival is lower than obtained with surgery. Thank you for your attention.
Well, thank you very much, Professor Sauvanet. This was great. Thanks for sharing your amazing long year experience with us, and for pointing out that, of course, we have to see what we treat. This is not easy in insulinoma sometimes, and also to stress out that, especially in this benign disease, it's important to look into quality of life, long-term results, diabetes. It's, I think, very, very important. So I can see on the chat that, thanks, Julie, you shared some of the papers, and most of the consensus documents and guideline papers are open access. So please have a look. And probably some of you, if you agree, can share your PDF slides with the attendees, but we can discuss this at the end. So the final specialist who is missing now is the medical oncologist. It's a great pleasure for me to introduce Melissa Frizziero. She's originally from Italy, from Verona, as Stefano told me. So it's also nice to meet you for the first time. Melissa, and she's now working in Manchester at the Christie's, which is also a very famous unit in HPP and NET treatment. And she's now giving a talk on how to treat metastatic functioning NETs with systemic treatment. Thank you very much.
Okay. Good evening to everyone. Thank you for inviting me to present today on the medical management of functioning metastatic neuroendocrine tumor. These are my disclosures. So this is a snapshot of basically what has been discussed previously. I think Maribel presented the clinical features of functioning neuroendocrine tumors very nicely. Just to summarize, all in all, functioning neuroendocrine tumor represent a fourth of all neuroendocrine tumor diagnoses. Here we go with the pointer. And these are the most common types of functioning neuroendocrine tumors. They're mainly localized in the pancreas and duodenum or in the small bowel. These are the main symptoms and signs, and these are the hormones that we use to diagnose and monitor these tumors in the blood. Sorry. Right. So what I want to emphasize here is that the quality of life of patients with neuroendocrine tumor can be significantly impacted in the presence of hormone syndromes. And sometimes this is also reflected in a shorter overall survival. For example, especially in the case of carcinoid syndrome, you can see in these survival curves, we have patients with carcinoid syndrome in green, and the survival is much worse compared to patients with non-functioning NET here in dark red, or patients, for example, with insulinoma here in blue. So when we have a patient with a diagnosis of a functioning neuroendocrine tumor, or even when we have a clinical and biochemical suspicion, but we haven't completed the diagnostic workup yet, in patients with severe symptoms, the first thing we need to do is, sorry, I have problem with my, here we go, with my slides. Okay, so the first thing we need to do when we have a clinical suspicion of a functioning neuroendocrine tumor, or whether we have pathological confirmation or not, we need to start somatostatin analogs and also medical treatment to address symptoms specific of each syndrome. So somatostatin analogs, what we use is long-standing, long-lasting somatostatin analogs in the form of lanreotide or octreotide. These are subcutaneous or intramuscular injection given to patients every 4 weeks. And if this is not sufficient to achieve symptom relief at the beginning of the treatment, we can also top up with some short-acting octreotide given multiple times during the day. But why do we use somatostatin analogs to treat symptoms of functioning neuroendocrine tumor? The reason is that somatostatin is actually an inhibitor of hormone secretion and cell proliferation in neuroendocrine cells. So in the presence of a neuroendocrine tumor which expresses high level of somatostatin receptors, physiological levels of somatostatins are not sufficient to maintain the inhibitory control, so we need to give somatostatin analogs. So somatostatin analogs were developed in the 90s actually, and they showed efficacy in control symptoms related to functioning neuroendocrine tumor. You can see here with symptomatic response in between 50% and 100% of patients. But later on, we have two studies showing that actually somatostatin analogs can also suppress proliferation of tumor cells and delay tumor progression with impact on long-term survival. So that's what we do. But in parallel, we also need to give, we said, medical treatment to treat symptoms specific of each syndrome. For example, in the case of carcinoid syndrome, and even more so in the case of lipoma, it's very important to treat the diarrhea, the dehydration, and the electrolyte imbalance. In the case of a patient with heart failure, in the presence of carcinoid heart disease, we need to give treatment for heart failure with diuretics, beta blockers, for example. In the case of gastrinomas and insulinomas, we need to give high-dose PPI for gastrinoma and dioxazide for insulinoma. Bear in mind that in the case of gastrinoma and insulinoma, at the very beginning, especially when the tumor is still localized to the primary organ, we may not need somatostatin analogs, but mainly medical treatment. So this is just to reiterate what has already been stressed before about the risk of carcinoid crisis in patients with carcinoid syndrome. Let's say that what I want to highlight that whenever we have a patient with a functioning neuroendocrine tumor, there's always the risk of a sudden flare-up in their hormone syndromes due to a rapid release of high levels of hormones, in this case serotonin, in the blood. And these crises can be life-threatening. So what we need to do, and can lead to hemodynamic instability and even hospitalization. So we need to recognize these crises very soon and treat them straight away. So usually these crises are triggered by procedures such as biopsy surgery, interventional radiology procedure, or even nuclear medicine procedure. And what we do is to give periprocedural prophylaxis to these patients. Sometimes they can occur spontaneously at some point during the treatment of the disease. And we usually treat them with octreotide, subcutaneous in repeat doses, or continuous infusion. And also sometimes we need to support, provide hemodynamic support and corticosteroids and hydration. Once again, I want to reiterate that we need to watch out for signs or symptoms of carcinoid heart disease. This has been covered before. I want to highlight the need to screen for carcinoid heart disease, potentially in all new NET patients, regardless of the functional status, or at least in patients with carcinoid syndrome or raised level of 5-HIAA. So we need to measure NT-proBNP in the blood, usually perform a cardiac examination and also an echocardiogram. And if we have concern from these tests, we need to refer to cardiology. And patients, sometimes they end up having valve replacement or other cardiological intervention. So what do we do now? Let's say that we managed to get on the top of our symptoms. We have all the diagnostic tests that we need to discuss in our multidisciplinary MDT. So we have our MDT discussion, and the first question for the MDT is always, is this tumor resectable? We're talking about a metastatic functioning NET. We are talking about a metastatic tumor. So what do we mean for resectability? We mean that both the primary tumor and all the metastatic sites can be potentially resected with radical intent. So we are aiming for a R0 or an R1 resection. So if the answer is yes, what we plan to do is surgery, one-step or two-step surgery. We use perioperative octreotide. So in this, I think we differ from Toronto. Once we have completed surgery, if it is a two-step surgery, at the end of all the surgical procedure, we perform post-operative imaging. If this is clear, we stop somatostatin analogs and we keep the patients on follow-up. If the answer is no, the patient is not resectable, the tumor cannot be radically resected, we opt for, the recommendation is for systemic therapy. So what is the systemic therapy that we offer to patients with unresectable metastatic functioning NET? So if we have a slow-growing tumor with a low proliferative rate and a low symptom burden, we just continue with somatostatin analogs. Also, we have, because they're not only useful in controlling the symptoms, but we saw before that they can also prolong survival. If we have more aggressive feature, for example, a more aggressive tumor that grows more rapidly with a high proliferative rate or high volume disease and symptom burden, what we do, we combine somatostatin analogs with other oncological systemic treatment in the form of chemotherapy. In Manchester, we mainly use temozolomide capecitabine chemotherapy, or in the form of protein kinase inhibitors, such as everolimus, which is an mTOR inhibitor, or sunitinib, which is a multi-kinase inhibitor and an anti-angiogenics. So what happens if we don't manage to control the symptoms with the first line of treatment, or at some point during first line treatment, we lose symptom and biochemical control? So in this case, if we still have low symptom burden, so we have a flare-up in symptoms, but it's still relatively manageable, and we have evidence of radiological stability on imaging, the first step would be to escalate the medical treatment. So we usually increase the dose of somatostatin analogs, or more often, we increase the frequency. So we use a shorter interval, meaning instead of 4 weekly, we often use 3 weekly, for example. We can add telotristat, which is a serotonin inhibitor, or we can add to somatostatin analogs, we can add interferon alpha. These are not available in the UK, but in some countries are available, and this is common practice. Alternatively, we can switch to another somatostatin analogs, which is pasireotide, which targets multiple somatostatin receptors and is proven more effective in controlling symptoms of a functioning NET. But what if we still struggle achieving symptom control, or if we have a tumor with more aggressive feature and higher volume of disease, especially in the liver, or if we have evidence of radiological progression? So we go back to the multidisciplinary MDT and we discuss our option. And we have several options, actually, which include PRRT, liver-directed therapies, and medical treatment, and also is a very important cardiological input in the case of cardiac carcinoid heart disease. So let's start from PRRT. I'm not sure how many of you are familiar with PRRT. So this is a nuclear medicine treatment where we use basically a somatostatin analog, which is combined with a radioisotope, most commonly lutetium-177. So this compound is given to the patient intravenously and basically bind the somatostatin receptor, especially somatostatin receptor 2, expressed at high level on neuroendocrine tumor cells. And the compound is internalized in the cells and deliver radiation selectively and more effectively to neuroendocrine tumor cells, limiting the damage to the surrounding healthy cells. So PRRT is licensed in the UK and Europe in the second-line setting of patients with neuroendocrine tumor following this phase 3 clinical trial, which was a game changer in the treatment of neuroendocrine tumor, NETTER-1. In this trial, patients were randomized to receive PRRT in combination with somatostatin analogs or high doses of somatostatin analogs. These are all patients progressing after somatostatin analogs. You can see that PRRT led to a significant improvement in progression-free survival, overall survival, and response rate, and we achieved response on average in 1/5 of patients. But what is very important in the context of functioning neuroendocrine tumor is that PRRT has also proven effective in achieving symptom control, in improving symptom control. As you can see here, compared to high-dose somatostatin analogs alone, we can see that we most likely achieve symptom control with PRRT, such as diarrhea, and ultimately, these significantly impact on the quality of life of our patients. This is another retrospective study looking at the effect of PRRT on symptom relief in patients with functioning neuroendocrine tumor. You can see here that PRRT lead to reduction in diarrhea, flushing and biochemical response in between 50% and 70% of patients with functioning neuroendocrine tumor. Another strategy that we discuss in the multidisciplinary NDT in patients with progressive functioning NET or with refractory functional syndrome is liver-directed therapy. So we usually consider liver-directed therapy preferentially when there is no progression of extrahepatic disease. So we have a disease which is progressing in the liver, but is substantially stable elsewhere. So this procedure includes debulking surgery, ablation, and intra-arterial approaches. So I'm starting from debulking surgery. So the debulking surgery to the liver has been proven effective in the treatment of liver metastases from neuroendocrine tumor and in symptom relief. This is a large study, including 178 patients with a functioning neuroendocrine tumor. You can see that liver surgery led to complete or significant partial symptom remission in nearly all patients treated with surgery, with a low risk of lethal complications. The median symptom-free interval was around 3.5 years and a half, and was significantly longer in patients undergoing a more extensive surgery, although at the expense of a higher risk of perioperative complication and morbidities. And this translated in a survival advantage, so patients receiving a more extensive or a complete debulking surgery to the liver survive longer. In the same study, they show that basically over time, there is an increased tendency to favor intraoperative ablation combined with a less extensive surgery over a more extensive and major hepatectomy, probably to reduce the risk of perioperative comorbidities. When we talk about transarterial interventional radiology procedure, so this is basically an approach, which is an interventional radiology approach, whereby nanoparticles, usually in the forms of bits, are injected through an arterial access into the arterial branches of the hepatic artery to starve the tumor from oxygen supplies to induce ischemic necrosis. So we can perform embolization alone, which is called TAE, or we can combine embolization with chemotherapy, local chemotherapy, TACE, or with radiotherapy, so-called TARE or SIRT, selective internal radiation therapy. So in SIRT, usually the beads are combined with a radioactive compound, usually yttrium-90. And this is the results of a very nice pool meta-analysis, including more than 70 studies, and including thousands of patients with neuroendocrine tumor, 60% of which have a functioning neuroendocrine tumor. You can see what is the impact of these embolization approaches on tumor response and also on symptom control. You can see that approximately 85 to 90% of patients achieve tumor control with embolization, and we achieve symptom relief in 55% of patients with embolization or chemoembolization, and a bit more, 75%, approximately 75% with SIRT or radioembolization. So we don't have good quality comparison data between these procedures, but at least in the Christian list in the UK, this is our practice. Basically, we prefer surgery when we estimate the high probability of achieving complete debulking in the liver. That's where we consider surgery, and we have controlled extrahepatic disease. We favor TACE or embolization when we only have a few liver lesions that need to be targeted and treated, still in the presence of controlled extrahepatic disease. And we favor SIRT when we have more lesions in the liver, higher disease burden in the liver, and larger lesions. PRT is usually favored as second-line treatment regardless of whether we have controlled disease outside of the liver. This is the proportion of patients where we achieve symptom relief with the different procedure. In terms of survival advantage, probably the best we have is surgery provides a longer survival advantage. I guess this is also because the selection of patients. These are patients usually where we can aim for curative surgery, and they have, by definition, a better prognosis. So these are the medical systemic treatment that we can use to achieve better control on functional syndrome. We can also use chemotherapy in the form of temozolomide capecitabine or kinase inhibitor if we haven't used them in the first-line setting. And we also need to consider, as I said before, cardiological input to assess the risk of heart failure and valve failure. The take-home message, one of the main take-home message, never stop somatostatin analogs for patients with a metastatic functioning NET. No matter what, no matter treatment they're going for, we need to maintain them on somatostatin analogs because it's very important to avoid a rapid deterioration in hormone syndrome. So what is the take-home message from the talk today? So the first thing is important, as Maribel and Julie have highlighted multiple times during their talk, is very important to be able to recognize hormone syndrome related to neuroendocrine tumor because they can be life-threatening and we need to intervene sooner rather than later. Somatostatin analogs are critical to control functioning syndrome from neuroendocrine tumor, and they should never be stopped. They should be offered to patients lifelong. It's essential to discuss each case in the NDT, especially for all patients with NET, really, because they are very complex diseases, especially if we're dealing with a functioning neuroendocrine tumor. And very importantly, if we are suspecting a carcinoid crisis or we are struggling to control a functioning syndrome from a pancreatic NET, we need to consult endocrinology and cardiology rapidly. If we have a refractory functional symptom, or we have syndrome, or we have a progressive functional neuroendocrine tumor, we have different options. Bear in mind that we don't have strong evidence comparing this procedure, but they can be used as sequential treatment or in combination, and these are all complementary. And I think the main take-home message from today's webinar, I think that is very important to educate specialists with a different expertise other than neuroendocrine tumor on the possibility of these patients developing hormone syndrome that can be life-threatening, and for them to be able to manage patients safely. And with this, I'm concluding my talk, and I'm going to thank you all for the attention.
Thank you, Melissa, for this very comprehensive and clear talk. We are running a little bit late, but I think that we have time for one or two questions from the chat. There is an interesting question. I think maybe Maribel can try to address this. Can an asymptomatic patient develop crisis intraoperatively?
Yes, it's not an infrequent, it's infrequent.
Yeah.
But you might find someone that you ask in the consultation for all the symptoms, and it's usually liver metastatic disease of a small bowel. That patient doesn't have a lot of syndromes, and that's why I think we have to assess 5-HIAA in the first visit of these patients, although they are not symptomatic, because sometimes it happens, yes. It's not frequent, but it can happen.
So may I ask you, Maribel, do you think for each patient, even those with a clear non-functioning, for example, small intestinal tumors with a normal level of 5-hydroxydolacetic, is always necessary to ask for an endocrinologist evaluation before surgery, especially in the view of these possible misdiagnosed functioning tumors?
In my hospital, all of the NETs go to endocrinology and oncology. We have like a common consultation, so we check all the patients together. Yes, I think so. Yes, it's important for the surgeons to be educated to ask these proper questions, but I think so, yes. What
Okay.
can I say? It's what I do every day.
Yes. So another question for Professor Sauvanet. What are the current recommendations for lymphadenectomy in insulinoma and other types of NETs? But probably insulinoma is the topic of
But
of the
I
disease
think there
right
is
now?
no need for lymphadenectomy except for when there is some enlarged lymph node intraoperatively or suspicious lymph node on preoperative imaging, or some findings suggesting that it could be a malignant disease, such as vascular involvement and so on. But usually it's a benign disease, and if you can perform a small lymph node picking, but usually in more than 90% of cases, the lymph node are negative.
Okay. Another question for Melissa, but then I want also to challenge my friend Julie. Any comments on liver transplantation for a resectable liver metastatic disease in this setting?
So we usually refer to a transplant center in Birmingham here in Manchester, highly selected patients, very young. We had multiple discussions even within UKNet, which is the UK Society of Neuroendocrine Tumor, and I think the clinicians are split because of the need for long-term, long-life immune suppression after liver transplant and the possibility of the tumor coming back. We tend not to do it except for highly selected patients, where there is no other options and very young.
Julie, what do you think? A surgeon point of view.
Yeah, some people find it a very attractive option, especially in neuroendocrine, because it's an indolent disease. So the concern over immunosuppression is not as significant as it would be in colorectal liver mets or HCC, for example. And the answer for me is that it's exceedingly rare and it's exceptional cases. If you have 15 minutes, I can give you an entire talk on this. But essentially, the typical criteria for liver transplant that were set by the Milan criteria a number of years ago are patients that these days we would operate, right? There are patients with liver tumor burden less than 25%, portal drainage, 1 year stability. Like those are patients that in this day and age would get a liver debulking and would not. So real patients that would meet those criteria for transplants are very few. And that wouldn't go for surgery. And then when you operate and transplant outside of Milan, that's where the outcomes are not really good, is what the literature suggests. So that leaves very few patients that would truly be candidate and benefit from a transplant. In our experience, the ones where we've done it are exceedingly young patients with uncontrollable functional syndrome. So because those are the ones where it's not so much an oncology decision than a quality of life and an endocrine decision, where it's just impossible to control their endocrine symptoms. And, as we know in neuroendocrine tumors, that's not what's going to lead to a patient's death. It's not the endocrine syndrome. They live for a long time with that and they're miserable and it's very debilitating. So those are the few that we've sent. But we have the largest practice in Canada and we're the largest practice in North America. And I can count on one hand how many patients we've transplanted or sent for transplant in the past 10 years.
Oh, the last question for Professor Sauvanet is again, a very surgical question about the surgical technique for neuroendocrine tumor located in the tumor in the pancreatic tail or body. I think you can also consider them. Is it always necessary to perform a RAMS, or I would say a standard distal pancreatectomy with splenectomy, or can we consider a spleen preserving distal pancreatectomy?
I think there is an important place for spleen preserving pancreatectomy, distal pancreatectomy. I think in almost every insulinoma, because they are benign, and there is some recent papers suggesting that there is no difference regarding from USA or from France, suggesting that there is no difference regarding long-term DFS between spleen preserving and spleen resecting distal pancreatectomy. The benefit of spleen preserving is observed in the early postoperative period, because the postoperative course, to my opinion, and to the meta-analysis is more simpler.
Okay, thank you. So I think we have definitely to finish our webinar. It was very, very interesting. Of course, I would like to thank all the speakers for the great talk. all the participants, and of course, ESSO for the organization and ITM for the support. I think we'll see again in the future for other webinar on neuroendocrine tumor. In the meantime, have a very good evening, and thank you again to all of you. Bye.
Thank you.
Thank you very
Thank you.
much.
Thank you, everyone.
Thank you all.
Bye.
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 Goodbye.